Hi, everyone, and welcome to my presentation on serving in underprivileged communities. My name is Eric Dio. Real quick, I'd like to thank the Forward Thinking Chiropractic Alliance student team for asking me to do this. There's an absolute stellar lineup this weekend, and I'm honored to be even considered. So let's get right to it. So who am I? None of this really matters, but some people may be wondering who the guy talking to you for the next half hour is. I've been up and down the East Coast for school and ended up here in Connecticut for chiropractic school. Fortunately for me, I think this was the right choice. I have some prior research experience. I used to work in a neuroscience lab, working on ALS and stroke research. But since starting chiropractic school, I have had the chance to work on a few projects, one related to chiropractic curriculum, another about dry needling for spine-related disorders. I have two wonderful children and a beautiful wife that has to put up with my academic and professional journey, at least thus far she has. Let's jump right into it. So what do? I'm a second-year resident in the neuromusculoskeletal medicine residency program at the University of Bridgeport. Though through this program, we're placed in different health centers in Connecticut to provide chiropractic services. I'm also pursuing a diplomate in neuromusculoskeletal medicine. Now, as part of the residency, I was placed in a few locations as medical staff for the Community Health Centers organization. The Community Health Center, Inc., or CHC, is a federally qualified health center, meaning they have to meet certain requirements, and they receive funding from HRSA to provide primary care and other services to underserved areas. To become a federally qualified health center, there are stringent requirements and a required sliding fee structure for the uninsured, although there are certain advanced payments received from government health insurances which help to offset this. Through working at the CHC, I've had the pleasure to work with some amazing medical doctors, DOs, PAs, nurse practitioners, podiatrists, dentists, dietitians, mental health professionals, and others, all treating the same patient cohort under one roof. Working for the CHC has really been a pleasure thus far. Their mission is best encapsulated in the organizational motto, where healthcare is a right, not a privilege. It's something that really spoke to me when I was considering this following graduation. Now, before I begin, I'd like to let everyone know that I'm not an expert. I'm a recent grad with somewhat of a unique perspective given the setting I work in. I'm not going to try to dazzle you with a ton of buzzwords, metrics, or sureties. When I originally envisioned this presentation, I started thinking like I was teaching a class at university. I wanted lots of numbers and metrics about underserved communities and health disparities. And while all that is very important, and I do discuss some of that, I'd really like to take the time to try and shed some light about what it's like in the trenches in this sort of setting. The good, the bad, the ugly. Practical information that one day hopefully might be of some use to you in clinical practice. Now, maybe everything I talk about today are things you already know, or at least think you know. I certainly thought I did at graduation, but I implore you to take the time with all your patients, regardless of their personal, professional, mental, or financial backgrounds, and become an advocate for their health. In a world where the dollar speaks and little else, our patients need us as doctors and as people. Now, I don't have any numbers to back this up, but in my experience, your average chiropractic patient is going to be in the middle or upper class income bracket. These are the people with insurance, the people we want in our office, as these patients enable the chiropractor to have financial success. We spend a lot of money on our degree, and we deserve to be compensated for our expertise and our outcomes. There's nothing wrong with this. But the millions of Americans who do not fit into this mold, most of whom have Medicare, Medicaid, or uninsured, often never see a chiropractor. And the ones who do often end up in less scrupulous practices. At least that was my experience. I was living in Section 8 housing, barely scraping by, had chronic back pain, which would sometimes render me unable to work or function properly. I found a chiropractor on Groupon and was roped into a long-term treatment plan because of the dozen silent killer subluxations I had in my spine. I made monthly payments, and guess what? I got better. I was in less pain. My mental health improved. work and school weren't so draining because I was able to show up and not think about my searing back pain the whole time. But the fact is that I had to be drained of thousands of dollars that I frankly didn't have. It was a disservice to me, and it's a disservice to all those patients who have been likewise duped. Um, as someone who has seen the light as it relates to chiropractic care and has dedicated myself to being evidence informed and aggressively ethical, I wanted to work in a setting which allowed me to reach those people who needed my care best. Thankfully, I was able to find something like that here in Connecticut. Now, a setting like this, working in underserved populations, particularly in the community health center, federally qualified health center setting that I work in, it comes with its difficulties. First and foremost is patient compliance. Patients in underserved communities come in all flavors, but a general theme that I've seen in practice is an increased incidence of mental health disorders, complicated medical histories, conditions and comorbidities, tobacco use, illicit drug use, physical inactivity, obesity, or nutrition, or often with an inability or no desire at all to change. All of these things and much more as it relates to the demographic have impacts on patient response to the care provided. Now, this is not unique to chiropractic patients either. We often have local medical doctors come into the CHC who were previously in private practice that experience significant difficulties in patient management, most notably as it relates to compliance. In this setting, you experience a lot of interprofessional collaboration in co-managing cases. And as a new grad, at least for me, it was a daunting task. You quickly realize how little you know and how beneficial it can be to have a patient's PCP an instant message away. Conducting yourself in a knowledgeable but not a pushy manner as it relates to conservative musculoskeletal care is the easy in to the good graces of other providers and helps to create an easy referral pathway that can benefit patients who may have transportation issues, as I will discuss later. One really beneficial experience I've had was the ability for new nurse practitioner residents on site to shadow me for a day. It allowed them to see what I do and why for many neuromusculoskeletal conditions, the on-site chiropractor may be the right first-line treatment. Now, that doesn't mean I haven't gotten improper referrals. No, I don't want your low back pain patient with bowel incontinence unless you've shown that the incontinence is from something other than his spine. I've had to realize through this experience that I don't need to be great at everything, but I do need to get a patient to the appropriate provider. And being part of the team that gets the patient to the right place can be, in itself, very fulfilling. Talking about the setting, you have to talk about health disparities. There are many dimensions to health disparities, including things like race or ethnicity, gender, sexual identity, age, disability, socioeconomic status, geographic location. Now, socioeconomic status is important because it's a summary measure of lifetime. Socioeconomic status is important because it's a summary measure of lifetime exposures to hazardous circumstances or behaviors, and this goes beyond the risk factors for non-communicable diseases that policies usually address. Now, within this subgroup, Black Americans and Latinx peoples are often overrepresented, particularly in the socioeconomic disadvantaged groups. It's fitting when discussing health disparities that I also address social determinants of health. Now, you can read them on the slide, but they're conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions. Beyond this, now, overall, at least in the U.S., as per a study in 2016, an estimated 20.4% of U.S. adults had chronic pain, and 8% of U.S. adults had high-impact chronic pain. Both were more prevalent among adults living in poverty, adults with less than high school education, and adults with public health insurance. When coupling the previously mentioned health disparities with a population that is also overrepresented in incidence of chronic non-cancer pain, you can really see how the need for chiropractic services may be beneficial. Many of these patients have barriers in access to care, financing their care, racial or cultural acceptance. They may have unequal social, economic, health, and geographic conditions related to their care. Quality of care has been shown to be 40% poorer in Blacks, American Indians, and Alaska Natives, as well as 60% poorer in Hispanics in core measures than non-white Hispanics. Now, underprivileged communities will also have an increased homeless population who experience barriers, including finances, paying for their care, transportation, living conditions, including things like sanitation, medication, appropriate diet. They have an increased incidence of acute and chronic medical disorders, mental health, and substance abuse problems. These patients are at a greater risk of assault, victimization, and exposure to harmful environmental elements. There are measures to eliminate socioeconomic differences jeopardizing health. Things like community health center programs, rural health center initiatives, public housing, primary care programs, healthy school and healthy community programs, and healthy care for the homeless. Getting a little bit into what I see personally. So a little bit about the demographic information for the patients that I see at the community health center. Something not listed here, but ubiquitous is the homeless population, as I previously mentioned. It's easy to group people into those with housing and without, but as with most things, there are shades of gray. How about those sleeping on a different family member's couch every week, or those involved in domestic disturbances? Yes, sometimes you need to treat people on both sides of the issue. These people are often in and out of their homes on a regular basis. Many have no heat in the winter, they have mold in their walls. How easy do you think it is for these people to perform the home exercises you gave them when they're trying to do curl-ups on the floor and they're interrupted by the roaches crawling across their stomach? Or where there isn't a place to get on the floor because you sleep on a park bench in the cold. Getting creative with home exercise plans and modifying activities of daily living becomes an art form, and it is something I'll talk a little bit about later. Now, at CHE, there's a large cohort of chronic pain patients. I'd estimate that more than 80% of the new patients referred to me have also never seen a chiropractor before. Of the remaining 20%, 15 of those have only ever seen a chiropractor for a personal injury case. And unfortunately, most have seen the less scrupulous chiropractors. Now, there's a smattering of comorbidities, some more specifics that I'll get into a little bit later. But mental illness, which plays a huge role in patient care. You really have to ask yourself sometimes, does the patient really grasp and understand their plan of care? Do they understand what I'm saying, and could they repeat it back to me and explain it? I see a lot of patients with severe systemic and internal disorders. Most are chronic, including things like kidney disease, hepatitis, HIV and AIDS, and others. I have many English as a second language patients. The specific language is often location dependent in a setting similar to an FQHC, but generally the English as a second language population will be higher in underprivileged communities than in your average population. I know for me at least, I have a great number of Spanish-speaking patients. I see Polish, Polish-speaking patients, Bengali, other Indian dialects, Thai, Portuguese, French, Creole, and others. Now, getting down to the meat and potatoes, I'm talking about some specific patient examples. I hope to provide some practical examples and useful takeaways from some of the patients I've seen. I'd like to start saying I won't be giving a full health history and physical exam findings for all these patients. There are people much better suited for that job, and maybe you're all light years ahead of me when I graduated, but I always appreciated real-world scenarios with applicable takeaways for patient care. Now, the first patient I want to talk about here is a 56-year-old female mother with referral orders including low back pain and bilateral sciatica. Symptoms were basically unchanged over the last 3 years. She came in with a very slow, abnormal gait pattern. We finished up a basic history of present illness, and I got into her red flag questions. Are there any issues with your bowel or bladder? Are you having any accidents in your pants? No. It's careful to read the room and make sure your patient understands the question here. Don't hesitate to use basic words and be direct. Sometimes I'll say, have you been accidentally pooping or peeing when you didn't realize you had to go? Now, in this case, unfortunately, I got a yes. And unfortunately, this isn't the first time. She had seen a neurosurgeon 3 years ago who told her she should have surgery and that it'll likely fix her leg pain and her incontinence, but she may have more back pain. And I'd like to stop here real quick and talk about the importance of avoiding nocebic language. Oftentimes with patients, we say things because we understand the meaning behind the word. And for many patients, that's not so. Using specific language that a patient can understand in avoiding the type of language that's going to allow them to catastrophize constantly is very important with patients, all patients, but particularly here in the underserved population. So anyways, she declined the surgery and basically said, I hope it works itself out. She went through physical therapy 3 times without benefit. She noted that physical therapists were often worried to have her do any exercises, and the usual treatment was hot packs and ultrasound. She's had regular intermittent urinary and bowel incontinence for the last 3 years, which worsens with her low back pain flares. She has mild saddle anesthesia, been worked up by multiple providers and specialists since. Anyways, after our examination, I advised her to follow up again with the surgeon immediately, although in some likelihood this was going to be permanent, at least the bowel and bladder incontinence. She now has to wear an adult diaper, and she really is just looking for a little relief from her low back pain. Now, I brought up this example for a few reasons. One, don't forget to ask your red flag questions. You get used to hearing no's, and at least for me, it could be easy to feel more comfortable when patients are referred directly from their primary medical provider. And also, because this patient was obviously lost in the system somewhere, I have to make sure I'm dotting my I's and crossing my T's. Being an advocate for proper care for all patients is our utmost duty as doctors. Now, the next patient is a brash lady. She's in her early 40s, very difficult personality to deal with. And she's very difficult to read, both in her relatively flat affect and her tone. She has tremors of unknown etiology. She's been worked up by a dozen neurologists and other specialists. Insomnia, hypertension, coronary artery disease, obesity, type 2 diabetes, hypothyroidism, systemic lupus erythematosus, GERD. She had OA of both hips. And this lady, she had pretty much resigned herself to the status quo of her chronic low back pain, or worse. Years of physical therapy and medication, always focusing on her pain level and range of motion. This patient had specific things in her life that she wanted to be able to do again. She wanted to walk her dog. She wanted to do the dishes without having to take a break halfway through. We were able to set specific, measurable, functional goals and develop an exercise and treatment plan to help meet those goals. And surprise, her pain level went down when she was able to meet some of these goals. We have to be there for our patients and make sure that their goals are your goals. Now, moving on for my next patient, a gentleman, chronic low back, chronic neck pain. He's homeless, hypertension, intrinsic eczema, cervical foraminal stenosis, cervical level scoliosis, and a smattering of other issues as well. But with this patient, he had no phone, he had no house. He would disappear for weeks on end. But he was one of the most gentle, kind humans I'd ever met. In addition to sometimes disappearing for weeks on end, he was also prone to loud verbal outbursts, which he called were his bad days. And this was in between his kind, gentle, natural demeanor. He was, again, somewhat difficult to manage, but a very fulfilling patient to work with. He didn't have access to bathing facilities or a laundromat and apologized profusely for the first 5 treatments, explaining every time how ashamed he was that he smelled. Patients understanding sitting down and having these conversations with patients and trying to be there for them, guiding them to the correct healthcare practitioner or community outreach program, or sometimes even just letting them vent for an extra 3 minutes can often be far more valuable from a clinical standpoint than 3 extra minutes of ART. This patient's treatment went well for his low back. We were able to find some specific exercises to decrease his pain and enable him to engage in regular activity without causing a flare-up. But these exercises had to be done in standing against a wall or on a bench. This led to some creativity on both our parts. His neck pain, which began following a lifting injury more than 10 years prior, did not respond to any of the treatments provided. And he ended up disappearing from our facility before I was able to get him a further workup. This is not uncommon in this setting, but I brought this example to stress the importance of developing a patient's self-efficacy and a useful home exercise program. And for me, at least, very important is a passable McKenzie evaluation. Now, my next patient, she's an epileptic, she has schizophrenia, Lyme disease, osteopenia bordering on osteoporosis, insomnia. She has a meningioma and another unknown brain mass that she was currently getting a workup for. Type 2 diabetic, sleep apnea, morbidly obese, GERD, neuroferritinal stenosis of the lumbar spine. She had to use a lumbar belt. She had a grade 2 lumbar retrolisthesis that was stable. And she often walked to her appointments with her personal cart. You'd often catch her waiting outside the office 1 or 2 hours before her appointment, listening to her CD player. She was a really big fan of Beyonce, and I can remember one of the times I got her talking, and it took almost 10 minutes to get her off the topic of Beyonce and get back to the actual treatment that we were doing. She was at first really hesitant to talk to me at all. She was unsure why she was referred to me. No treatment had ever helped her pain, and she wasn't being prescribed opiates anymore. So she didn't know what I could do. And honestly, most days it didn't feel like much. She was remarkably sensitized. Hands-on therapy was a game of graded hands-on care and home care, including desensitization, things like self-massage, skin rolling, or she called it pinch rolling. We were able to find some very basic home exercises, including something like the use of a towel for knee to chest stretches. And we had a very long conversation and explanation about graded exercise tolerance to try to help build up her walking stamina. Now, there were setbacks and difficulties, but when we finished care prior to the start of the pandemic, she had increased functional capacity and decreased pain compared to the start of her trial of care. And maybe she had just a little more faith in the people who were part of her healthcare team. There's a real importance in developing a solid and comfortable patient-provider relationship, learning how to talk to people, and becoming proficient in motivational interviewing, which, for those who don't know, it's basically, it's a counseling style for eliciting specific changes in behavior to help the patient you're talking to explore and resolve ambivalence towards basically a greater future. Now, a number of patients I've seen were referred to me for the express purpose of helping to aid them in former opioid dependence and relapse into heroin use. Many patients on Suboxone or methadone who have suffered psychological and physical traumas that the drugs they were using often help mask. This might actually be my favorite patient population to work with. I've been able to meet men and women fresh out of rehab or living in sober houses. In fact, I had one who told me that they were experiencing a lot of pain the night before and thought about using, but knew that they had an appointment with me the next day, so instead they did their exercises and went to sleep. It's the little things like that where working in an underserved population, these things can really lighten your day. These patients are often disregarded by healthcare professionals as drug-seeking. Their symptoms are sometimes not taken as seriously. I implore all of those students listening and all practitioners listening to not fall into this trap. Every patient needs our time and our attention. The next patient I want to talk about is a 42-year-old female. She's bipolar, polysubstance abuse, including alcohol, opioids, cocaine, included cannabis in that list. She had insomnia, bilateral sciatic symptoms. She could not extend beyond 20 degrees of flexion in standing or in sitting. She had multi-level bridging, lateral and anterior osteophytes in both the cervical and lumbar spine. She was severely sensitized with significant kinesiophobia. Just getting her to do some supine hook lying, lumbar rotation stretches twice a day for a week with this patient, and her subjective pain score was nearly cut in half. You have to get your patients moving. Passive care just doesn't cut it most of the time. Sometimes it's less about the movement you're doing and more about finding something they can do that gives them purpose and a glimmer of hope in their recovery. She'd often discuss with me about how one of her previous providers treating her back pain would do nothing but critique her form every visit. And it made her feel like her body couldn't do anything right. There's a time and a place for perfect mechanics, but you must be aware of your patient and their outlook. Remain positive and constructive in your discussions. This doesn't mean handle every patient with baby gloves. Learning the art of patient care it's fickle, it's difficult, and I'm learning more every day. But every patient is different, and of one. Not only in treatment style and approach, but also in the way you talk and approach each conversation. And patience, particularly for those who are suffering from mental illness or who may not be neurotypical. The last patient I want to discuss, a 41-year-old female, former IV drug user. She's 6 months sober. I noted prior to seeing her for the first time on her problem list that she had been diagnosed with discitis and osteomyelitis. On a recent x-ray, the report for which was received the day before I saw her, it noted a 52-degree lower thoracic lumbar scoliosis. Looking back through her records, she had been hospitalized and in a coma for 2 weeks. This was about a year and a half ago during her battle with the spinal infection. Now, she had no history of scoliosis prior to the spinal infection that I could find. It wasn't noted in any of the CT scans she had back in 2014. And unfortunately, I only had the radiology report to look at for that. As I just said, she was 6 months sober. She's just getting her life together. And I remember at our initial examination, she had an interview for a waitressing job that she was hoping to get. But she was afraid because she couldn't be on her feet for more than 10 minutes without searing low back pain. And even the Suboxone that she was taking, it wasn't cutting through the pain anymore. And she was afraid that she wouldn't last long on the job. On that initial exam, we were able to fully abolish her pain with some really basic standing extension exercises. I also discussed with her primary care, and we had her referred to an orthopedic specialist for the previous mentioned scoliotic deformity and continue tracking for progression. The takeaway here is that pain is not the only thing you're treating in most patients. It's the consequences for the pain. In this case, it was an inability to work and the potential for a drug relapse. I'd like to move on now to just a little bit of practical advice. Now, I tried to weave some of that practical advice into some of the examples above, but more than that, talking a little bit more about motivational interviewing. It's such an excellent approach for a patient who is fixated on something like the level of their pain or how much it limits them, despite a functional analysis telling you otherwise. You often have to meet these patients where they are on the spectrum of change. You don't need to immediately minimize their experience, but try to understand it and help shape their experience with discomfort and pain. So you can only walk 5 minutes a day. That's okay. What an excellent start. I bet we can get you up to 10 minutes in no time. With patients like this, smiles go a long way, although during the pandemic, I try to focus more on the tone of my voice and the wrinkles around my eyes for feedback. With these patients, you need to be present and let them talk. Those 2 extra minutes in which a patient begins to open up to you may be the first time they felt that a doctor has ever truly listened to them. You'll be surprised what you learn, and even more surprised by how appreciative and more apt the patient is to listen to your advice in the future. We need to be human. We need to be empathetic. We also don't need to be soft. You need to tell your patients what they need and be direct with your instructions. Furthermore, explaining your diagnosis and letting a patient ask questions. Many of them have never had a provider explain the what, the why, and the how of their condition. This sometimes has to be tempered. You have to learn to use understandable language, but also don't assume you need to use it. Ask patients if they understand in a non-judgmental fashion. Never assume a patient isn't intelligent by looking at their medical history, how they speak, or how they look, but really, this should go without saying. Almost as important as what you do to the patient is how you do it in the context in which the care is provided. Now, I can't stress this enough. And while I try to play up working in this setting because I really enjoy it. It's hard work. It's emotionally draining. The burnout rate for medical providers in underprivileged communities is far and above that which is seen in your average population. For many of these patients, full recovery may not even be an option, but focusing on how you can enable each patient to take control of their health, their pain, their struggles, and overcome it, becoming an advocate for their own health and have some light at the end of the tunnel. These are the small wins, or rather the big wins that you often need to take in at the end of the day so that you can wake up the next morning and do it again. What can you do now? Like I said at the beginning, you need to be there for your patients. You need to have their best interests at heart. Be understanding without being a pushover. Be aggressively ethical and never hesitate to go the extra mile. Take care of yourself. You can't help others unless you're healthy physically and emotionally. Now, there are many places to serve populations, underserved populations. Places like federally qualified health centers, rural health centers, even places like the VA hospital systems have very similar patient populations. Even private practice. I may not be the best person to ask, but there are thousands of people over at the FTCA page and the website who have tens of thousands of years of experience in helping people from all walks of life. Don't be a stranger. Ask questions. We don't bite, usually. This is my contact info. Feel free to look me up on Facebook or contact me via email. Never hesitate to reach out. I love talking about this stuff, and honestly, I'll probably learn more by talking to you than I'd ever be able to give. You'd be doing me a favor. Before I end this, I just want to give a big thank you to the Forward Thinking Chiropractic Alliance for helping me find my chiropractic family, enabling me to find my voice and realize that there are thousands of boots on the ground in the fight forward for the profession. Thanks, everyone, and I hope you enjoy the amazing lineup of speakers our students have put together. Have a great weekend.